Welcome to the new IPF Quality Reporting Measures and Bridge Appointments conference call. My name is Danielle, and I will be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. Please note that this conference is being recorded. I will now turn the call over to Kim Johnson. Kim, you may begin.
Hello, everyone. Thank you so much for attending today's webinar, New Inpatient Psychiatric Facility Quality Reporting Measures and Bridge Appointments. My name is Kim Johnson, and I'm going to be your facilitator for today's presentation. Our objectives for today's call are to discuss the current transitions of care measures for inpatient psychiatric facility quality reporting and the new measures which will be replacing them. Create awareness of the new IPF QR transitions of care measures which will be collected beginning on the new date of January 2017. And describe one best practice for outpatient follow-up visits post-inpatient psychiatric facility discharge with a mental health provider. Throughout the presentation, you may hear inpatient psychiatric facility quality reporting, which is a mouthful, abbreviated to IPF QR, and inpatient psychiatric facility abbreviated to IPF. I am the Behavioral Health Project Lead at Medistar, and I'm going to be joined today as well with our first speaker, who is Ross Gatsky. Medistar represents Wisconsin in the Lake Superior Quality Reporting, Medistar represents Wisconsin in the Lake Superior Quality Innovation Network. And Ross is the Quality Reporting Project Lead for Medistar as well. And our next guest after Ross is going to be Kirk Yockler from Milwaukee Area Healthcare System Pro Health. Kirk is over behavioral health at Pro Health and has some great information on best practices and lessons learned for increasing outpatient visits post-IPF discharge. Because Medistar is providing continuing education credit for this presentation, we do need to inform you. No commercial support has been received for this learning activity. The speakers have reported no conflicts of interest, and there are no planner conflicts of interest. For CE credits or a certificate of attendance, you must attend the entire session and complete an online evaluation that you will receive via email, or you may use the web link or QR code provided to you at the session. We encourage everyone to complete the evaluation to provide feedback on the session. I also want to thank our audience for your participation. You may have joined us because you were involved in one of our LS Twin projects in Minnesota, Michigan, or Wisconsin. And if you're interested in joining any of our projects, including the IPF project, please feel free to reach out to Ross and myself. We'll be sure to direct your questions to the right state and project representatives. We will have time for discussion at the end of today's presentation. If you have any questions during the presentation, please write them to everybody in your chat window on the right-hand side of your screen. You may need to click on the little arrow to see it. We'll also be accepting operator-assisted telephone questions once our speakers are finished presenting. With that, I'm going to turn it over to Ross.
Thank you very much, Kim, and thank you all for joining us today. As Kim had mentioned, I am a project specialist here at Medistar with a focus on quality reporting programs. My portion of the webinar will be broken down into two parts, the first being the rationale behind the inclusion of the new IPF transition measures into the IPF QR program, and the second part detailing the new content requirements of these new measures. First, I will provide a quick overview of the Inpatient Psychiatric Facility Quality Reporting Program. Simply known as IPF QR, the program was created to equip consumers with information about the quality of care that facilities provide so that they can make more informed decisions about healthcare options. Quality measurement performance is available to the public through outlets such as Hospital Compare. It was also intended to encourage hospitals and clinicians to improve the quality of inpatient care. Introduced by the Affordable Care Act in 2012, facilities began reporting IPF QR measures beginning with the fiscal year 2014 payment determination year. The IPF QR program is a pay-for-reporting program, meaning that eligible hospitals that do not participate in the program in a fiscal year will receive a 2 percentage point reduction to their annual payment update for that year. Originally a set of 6 measures, the program has gone to over a dozen measures as of the fiscal year 2017. When selecting measures for the IPF QR program, CMS focuses on areas that have high impact and support their priorities for improved quality and efficiency of care provided by IPF. The discharge measures were selected in the original measure set for a number of reasons. One was that many felt that patients would not be able to provide an accurate and complete report of important health information to their next level of care. Furthermore, these gaps in areas such as health literacy and documentation can create inefficiencies in communication between the stages of care. Discharge information and aftercare instructions may not be available at the patient's next level of care. And finally, the next level of care providers need to know important aspects of patient information, such as details of precipitating events immediately preceding hospital admission, the patient's treatment course during hospitalization, discharge medications, and next level of care recommendations. All of this falls under the values integrated care. Improved outcomes through the continuity of care and the development of seamless systems for patients with behavioral health disorders. The Post-Discharge Continuing Care Plan Created Measure, or HBIP 6, has 4 measures aimed at promoting effective communication and coordination of care. The continuing care plan had to include discharge medications, dosage, and indication for use that no medications were ordered at discharge, next level of care recommendations such as an appointment with an outpatient clinic or peer support for the patient, documentation of the principal discharge diagnosis, and the initial reasons for hospitalization. All 4 of these elements needed to be documented within the discharge plan to satisfy this measure. Simply creating the post-discharge plan does not ensure the necessary information is transferred to the patient's next level provider. Thus, CMS included the measure Post-Discharge Continuing Care Plan Transmitted to the Next Level of Care Upon Discharge, or HBIP 7. To satisfy HBIP 7, a provider would have to create a post-discharge continuing care plan with all 4 elements of HBIP 6 and transmit the document to the next level provider within 5 days of discharge. In this next slide, it shows you the performance averages for all 3 states in the Lake Superior Quality Innovation Network region, as well as the national average for both measures HBIP 6 and 7 for the calendar year 2014. Given the fact that the national averages were relatively high for both measures and the continuing focus to promote missing components of the transition of care continuum, CMS decided in the 2016 final rule that HBIP 6 and 7 were not robust enough. It was felt that the HBIP discharge measures were missing important elements within the transition of care process, and additional content was needed to fill in these areas. Also, as in all healthcare settings, not just IPF, readmissions are a constant concern and frequently targeted area for improvement. Additional steps can prevent gaps in care transitions caused by the patient receiving inadequate or insufficient information that lead to avoidable adverse events that cost CMS approximately $15 billion due to avoidable patient readmissions. Much of the content added to the new transition measures deals specifically with filling in these gaps. Additional requirements to the IPF QR transition measures can intuitively lead to better patient care, fewer readmissions, and more positive outcomes. A few areas in which additional requirements were needed were the sharing of diagnostic test results, as in some cases outpatient physicians and the patients themselves are not aware of pending test results at discharge, and this information gap is exacerbated if the results of the test require some action at the next level of care. Comprehensive medication lists provided at the next level of care can help prevent polypharmacy issues and medication errors. Personalized patient instructions provide complete and relevant information to both the patient and next level provider, and patient education can reduce preventable readmissions. And finally, current information and communication technology can facilitate the completion and transmission of a transition record within 24 hours of discharge, which could greatly reduce communication gaps and may have a positive ripple effect on patient outcomes. These additional elements are intended to improve the quality of care, decrease costs, and increase beneficiary engagement. For the second part of my presentation, I will discuss what these new transition measures are and what new content you as providers need to include to be successful with these measures. HBIPs 6 and 7 were removed by CMS from the IPF QR program on January 1st, 2016 and are being replaced by transition measures created by the American Medical Association. With the removal of the HBIPs measures, CMS added the two NQF transition measures. NQF number 647, the transition record with specified elements received by the discharge patient, and NQF 648, the timely transmission of the transition record. Data collection for these new transition measures will begin in Q1 of 2017 for the fiscal year 2019 payment determination year. IPFs were originally to begin collecting data on these measures in July of this year, and the 6-month gap between the removal of the HBIPs measures and the inclusion of the NQF transition measures was intended on giving providers the time to adjust to the new reporting requirements. However, CMS has since received a number of requests for further information about the new transition measures and questions about their interpretation, and thus decided last week that even more time was needed for IPF to prepare for these changes. So once again, data collection for both NQF 647 and 648, the new transition measures, will not begin until January 2017. So NQF 647 is a chart-abstracted measure that has 11 total content elements needed for inclusion for it to be a numerator submission. The denominator includes all patients regardless of age discharged from the inpatient facility to home or self-care or any other site of care. The measure excludes patients who died or left against medical advice or discontinued care. The content requirements for this measure are far more comprehensive than the previous discharge measure, HBIP 6. CMS decided that adding content to the new measures would aid IPS in improving the transition processes. Some of the new additions include documentation of tests and procedures at the inpatient stay, studies pending at discharge, and an advanced care plan. The numerator for NQF 648 is for patients for whom a transition record was transmitted to the facility or primary physician or other health care professional designated for follow-up care within 24 hours of discharge. Once again, the requirements of this measure are far more rigorous than the previous HBIPs measure. NQF 648 has a much smaller window for transmission of the record, which is 24 hours, than the HBIPs measure, which allowed up to 5 days. The transition record may be transmitted to the facility or physician or other healthcare professional designated for follow-up care via fax, secure email, or mutual access to an electronic health record. The time and the method of the record transmission should also be documented. And finally, NQF 648 requires only the transmission of the record, not that it was received. So if you were to discharge a patient on a weekend day and the next level of care provider's fax machine is turned off, as long as you have documentation that the record was transmitted by your facility, it would still satisfy the measure. This slide just displays the complete content requirements of the old HVIPS 6 measure and its replacement NQF 647. Just by a quick glance, you can see how much more depth the new NQF measure has, just based on the amount of additional elements alone. Over the next few slides, I will go into all 11 of the required content elements of NQF 647, broken down into different segments of patient care. For inpatient care, both measures require the principal diagnosis at discharge and reason for hospitalization or inpatient admission. The major difference here is the addition of the documentation of major procedures and tests performed during the inpatient stay and their summary results. CMS included this element because they felt that it was important for patients to understand which tests and for what purposes were performed and the implications of these tests. This knowledge can serve to further engage and empower the patient throughout their care continuum. As for how CMS defines a major procedure, they left that decision to the providers, so there is some intentional ambiguity there. For post-discharge and patient self-management, HVIPS 6 does not necessarily address this area, whereas NQF 647 has 3 content elements. The first being the patient's current medication list, which is to include documentation of all medications taken at discharge, including all continued and new medications. The element for studies pending at discharge was included to increase communication for studies that required some follow-up at the next level of care. And third, patient instructions were included to increase patient engagement and empowerment to take responsible steps in their care and reduce avoidable readmissions. NQF 647 also has an advanced care plan requirement, whereas HVIPS 6 did not. A written statement of a patient's wishes regarding future use of life-sustaining medical treatment or a documented reason for not providing an advanced care plan is needed, or documentation that the advanced care plan was discussed, but the patient did not want to proceed due to it being harmful to their cultural and or spiritual beliefs. And finally, for contact information and a plan for follow-up care, we once again see the additional, more robust requirements of NQF 647. The next level of care recommendations and discharge medication elements of HVIPS 6 kind of fall within NQF 647. NQF 647 requires contact information for a plan for follow-up care, which may include any post-discharge therapy needed, any durable medical equipment needed, and or family or psychosocial resources available for patient support. 24/7 contact information, which is satisfied when an IPF provides a patient with a number in which the patient can contact the facility with questions. Contact information needed for obtaining results of studies pending at discharge, and for the patient's primary physician or other healthcare personnel or site for follow-up care. The differences between HVIPS 7 and NQF 648 are more straightforward. Both measures require all elements of their respective discharge or transition record. For NQF 648, providers need documentation of all 11 elements of the transition record. The major difference here is that the time window to transmit the record to the next level of care has been reduced from 5 days post-discharge to 24 hours. More timely communication between the levels of care has shown to lower risks of rehospitalization, reduce medical errors, and improve overall patient outcomes. And as I conclude, I hope that we can all agree that care transitions are an important component of providing optimal services to patients in behavioral health. It can lead to improved communication not only at the patient to provider level, but between providers as well. There is also evidence that it reduces medication and clinical errors. And finally, it can create more patient engagement and empower them to make better decisions about their health. All the hard work you do as providers to improve the care transition process can lead to better outcomes not only at your facility, but also for the patient at the next level of care and beyond. This concludes my portion of today's webinar. I would like to thank everyone for joining me, and with that, I will pass it back to Kim.
Thanks, Ross. I think the changes to the IPF QR transitions of care measures are really important to be aware of, and they just show increased attention to the importance of successful care transitions. On a side note, Ross and I did have a good chuckle that when we originally were first planning this PowerPoint about 2 months ago, the transitions were going to happen in July of this year. And last week, CMS pushed it back to January 2017. So this just gives you an extra 6 months to really get prepared for your next reporting year. Also, when we were originally kicking around ideas for what we wanted to present for our IPS, we decided to reach out to Kirk because during our recruitment with Pro Healthcare, he brought up some really interesting projects and initiatives that Pro Healthcare had taken upon themselves to start doing over the past couple of years. And they've proven to be both sustainable and beneficial to patients. And we thought it was a really great opportunity for us to just kind of showcase what some different ideas on how to make a sustainable way to make sure patients are getting their aftercare visits happening. So Kirk, we're going to pass the ball over to you now. And Ross, Ross is going to pass it over to you.
Excellent. Thank you so much. So thanks both to Kim and to Ross and the Lake Superior Quality Innovation Network for their focus on behavioral health. And let me get us to, you've got some references there. I'll leave those there for a minute and then I'll get to my slides. So again, I'm Kirk Yockler. I'm with Pro Healthcare, and I'll be highlighting some transitional behavioral health services that support our IPF, which is an inpatient unit in a hospital, as well as some other interesting work that we're doing to integrate behavioral health services through our system, and hopefully that will be of some interest or value to the participants today. So a little background about Pro Healthcare and Pro Health Solutions. As Kim mentioned, we're in the Milwaukee area in Wisconsin. We're based in Waukesha County, which is essentially the western suburbs of Milwaukee. We have 2 hospitals, the larger one in Waukesha and a smaller one about 20 minutes away. We have 13 primary care clinics, and our footprint is almost exclusively in this county. Pro Health Solutions is our ACO. And that consists of 698 ACO providers currently, of which 361 are employed by Pro Healthcare. So some background on Pro Healthcare's behavioral health service line. So our inpatient hospital-based psychiatric unit, it's a 22-bed unit for adults. We service acute mental health issues, alcohol detox, and geropsychiatry patients. Our partial hospitalization program is a full-day, 5-day per week program for adults, probably a typical program. Mental health, dual diagnosis, and substance use disorder primary patients. We also have an intensive outpatient substance use disorder program and our opioid dependence program, which is an outpatient program as well. Our outpatient services include psychiatrists, psychologists, and psychotherapists, and we treat the lifespan, so kids to elderly. The department I'll be highlighting today is the Integrated Behavioral Health Services team. But first I'd like to give a little more background on our outpatient services as it relates to the need for transitional services. So historically, this department treated patients from all over and outside of the community, and our own Pro Healthcare physicians struggled with access to the services for their patients. As the ACO developed, we recognized the need to devote our resources to this group of providers, so we adopted the practice of limiting referrals to those patients referred by or at least connected to our ACO providers. We also began to increase our presence in the clinic setting. Co-location is kind of the first step in integration. So we added offices over the course of several years, and we currently have at least one behavioral health provider office in each of the 13 medical group clinics. And we're now looking at adding offices in buildings where higher concentrations of our non-employed ACO providers practice. This led to significant growth in referrals to our outpatient services, despite our being exclusive to the ACO, which in turn has led to some access issues. And this integrated behavioral health services team has become part of the solution. So historically, this team was a hospital-based department, considered an ancillary support service like social work or chaplaincy services. Their office was located in the hospital near the inpatient, the IPF. The team had a presence on the inpatient unit, behavioral health unit, for discharge planning purposes, and covered some of the clinical functions as well at times. In addition, they were responsible for assessing patients in the emergency department who presented with behavioral health issues and facilitating admissions to our inpatient unit. They also saw patients on the medical floors of our hospitals for behavioral health consults, the non-psychiatry or non-prescription question-related consults, and supported the psychiatrists who were engaged in the consult work. So some team members were fully licensed, others were working toward licensure. Even with the licensed providers, we were unable to bill for services as they were under the hospital tax ID number and therefore couldn't use professional billing charges. They also weren't able to provide much in the way of support to our clinics, as the bulk of their time was spent on hospital-based work. So in the current state, and this happened over the course of a couple of years really, we opted to move the department to the clinic division. We physically moved the team up into the professional building of our main hospital and established them as providers under the outpatient department's tax ID number, so they could engage in professional billing. We basically set them up as kind of a subgroup of providers of the outpatient department. And in doing so, we raised the bar on licensure, and so all team members are now fully licensed as well as certified to treat substance use disorders. So they have a specialty added to their license, or they have a full substance abuse counselor credential. The team stopped providing direct behavioral health services to the inpatient unit, and the unit hired its own behavioral health therapists to do this work, which are hospital-based employees, and it's non-billable work there anyway. The team continued the other behavioral health services it had historically provided, but is now able to bill for the majority of the assessments in the emergency department, and we're using the crisis assessment codes there, as well as many of the consults on the medical floors. In addition, the team is able to bill for clinic visits, for crisis assessments, which then led to our adoption of the bridge appointments as a new service. And that's sort of the focus for today. So these bridge appointments, again, as our access to outpatient services has been strained from the increase in ACO referrals, this team, the IBHS team, their flexible schedule really allows them to bridge the gap. So again, being able to provide behavioral health provider appointments within 7 days of post-discharge from our inpatient psych unit or the partial hospitalization program. Many of you are aware of the managed care requirements along with the other measures that on follow-up that are looking for that, so we're able to do that. they can see patients 1 to 3 times roughly to bridge the gap between discharge and then connections with a psychotherapist, whether it's within our own department or providers in the community. So they really operate as almost an EAP type bridge service. And then the clinic psychiatrists, in sort of response to the success of this model, have opened up appointments for post-discharge follow-up as well. So they sort of followed the lead of this team. So again, as our, let me just refine my place here. We've covered the bridge appointments. There we are. So I wanted to share some results with you for this department. Our fiscal year runs from October through September, and so these were as of the end of September of 2015. The significant thing here is that this department has historically been a cost center. They really had no revenue of their own. And so while it still represents a net cost to the organization, we've been able to reduce that cost considerably with the new net revenue. So 2,400 billed visits over the course of that year, 200,000 in net revenue, which translated to about 30% of the department cost, and really allowed us to make a case for expanding FTE in the department for fiscal year 16. So looking at some challenges and successes, on the challenge side, access to care, we're learning that our outpatient department is not nearly as large as it should be in terms of the number of providers in each discipline needed to support our ACO. We're actively recruiting, but it's clear that it'll be some time before we get to the right size in terms of having timely access to our services for patients connecting to our ACO. This has led to increased demand for those bridge services. We are recognizing some billing issues around Medicare. Many of you may know, if you have behavioral health services and providers, that licensed professional counselors aren't considered a billable provider for Medicare. It's a long-standing issue, and it relates to Medicare recognizing only licensed clinical social workers as providers of master's level behavioral health services. We've been challenged, at least in our area, to recruit LCSWs. And currently they represent less than half of our behavioral health therapists, so we have to be strategic when scheduling Medicare patients. We've also not been able to convince our organization that we can bill Medicare for the bedside consults that this IBHS team conducts, as there's CMS language around social work services being part of the DRG payment structure on the hospital side. Our argument is that the services we're providing are not the typical social work services, however. So we do intend to continue to press for clarification here and ultimately think that we'll be able to successfully bill for those services with Medicaid patients as well. On the successes, certainly we've seen an increase in completed post-discharge appointments within 7 days of discharge, and we're often able to do that sooner. We've been able to expand our billable services with this group. We've strengthened the continuum of behavioral health services. We definitely feel more confident in our ability to provide timely follow-up services with the bridge appointments in place. And, it's part of, I would argue, it's part of your responsibility if you have higher level services that you're not only responsible for those services, but you're also responsible for the transition to the next step. And so this has really helped us on our end. So where do we go from here? We do intend to continue to expand this team. Many organizations are moving toward using integrated behavioral health services in primary care. Our plan is to strategically place IBHS team members in the larger clinics in what we call a hub and spoke model, where they can also support the smaller clinics nearby. They can see patients for crisis and bridge therapy appointments as they're doing in our professional building of the hospital. And then the idea is that they would refer those that need ongoing therapy to our routine outpatient providers. Screening for behavioral health conditions is a growing area in healthcare as well, both in primary care as well as in hospital settings. And last year, Pro Healthcare implemented depression screening for patients age 12 and older in primary care. Over the course of 2015, we screened over 35,000 patients during that year. And this also led to an increase in routine referrals to our outpatient services, as well as urgent referrals to that IBHS team. The depression screening has a suicide question on there, and that's often led to some urgent referrals. We know that there are other behavioral health conditions beyond depression that are being missed, though. And so the plan is to ultimately conduct routine screening for anxiety, alcohol, and substance misuse, as well as trauma history. And we know that this will involve additional resources beyond the hospital and clinic providers and staff. So we're exploring models right now to support this work, along with the billing revenue available for some of these screening tools and screening procedures. You see telehealth on the slide. We haven't launched telehealth services here yet, but many of you have heard, it's certainly a growing mode of service delivery in the industry, and we'll likely start this over the coming year. Our intent is to start with psychiatry services to be able to support some of our more remote clinic settings without, losing that valuable provider time on travel. So lessons learned. Certainly we've recognized that supporting the ACO and, first and foremost is to our advantage, and that we need to be strategic about how we use our available behavioral health resources so that we can preserve access. We've also maintained informal partnerships and relationships with a host of public and private behavioral health service providers in the community. That includes our County Health and Human Services Department. We have a federally qualified health center in the community, and essentially all the major nonprofit organizations that are providing behavioral health services in our community. We reach out to them routinely. We learn about their providers and services, and we establish those referral pathways so that we can get our patients seen within the community in a timely fashion if we are unable to accommodate them within our own department. And we need those referral relationships when the outpatient services are only serving the ACO. Our IPF serves the community at large, so assisting those patients that we treat on the higher levels of care with finding follow-up resources when we're not providing them internally, we need to have those relationships. The integrated behavioral health services, much of the work was around exploring what billing codes we could use. With the billing folks in the organization, as well as our corporate compliance department, to sort this out was a critical element to our success. We also spoke to the growing body of research on the cost of untreated behavioral health conditions like depression, and the impact on the overall cost of care for ACO patients, as well as the relationship to chronic disease management, as well as to readmission rates. So this definitely helped us make the argument for adding resources to behavioral health departments that are typically not, profitable in their own right. They tend to be departments that lose money in larger health organizations. So we see the behavioral health service line as playing an integral role in population health management for our organization in the years to come, and we've been able to make this case successfully to our senior executive team. So that concludes my slides. I'm going to turn it back over to Ross, and then I believe we'll be fielding some questions.
And I'm going to turn it over to Kim.
Thank you, Kirk. That was really great information. We definitely look forward to hearing more about the continued success with all of your programs. So we've concluded our presentations at this point, and we are now ready to enter into the discussion. So I do want to invite all of you to ask your questions via phone or in the chat. Danielle, our operator, can you tell us the instructions for asking a question and if we have any questions lined up?
Thank you. We will now begin the question and answer session. If you have a question, please press star then 1 on your touch-tone phone. If you wish to remove from the queue, please press the pound sign or the hash key. There will be a delay before the first question is announced. If you are using a speakerphone, you may need to pick up the handset first before pressing the numbers. Once again, if you have a question, please press star then 1 on your touch-tone phone. Standing by for questions.
Okay, thank you. And actually, while we're waiting for some questions to get queued up, I have a couple that were submitted ahead of time. So I'm going to start with the first one. And Ross, this is directed for you. So we had somebody ask, I'm interested in understanding the drivers of the program. Improved communication and improved outcomes are clearly key. Are there any other drivers as well?
Well, since in the current state, the IPF QR program is only a pay-for-reporting program, so there really isn't any monetary incentives tied to improving quality as of yet. But some of the drivers that I can think of can be, well, if you look at some of the language that CMS uses, defined as improving patient outcomes, reducing readmissions, and any penalties tied to excessive readmission rates. And also the performance rates on the IPF QR measures are publicly reported and available on Hospital Compare, which again can help consumers make decisions on who to go to for their care. So there are definitely some incentives to perform well on not only these IPF QR measures, but all of them.
Okay, thank you. Danielle, do we have any questions?
We do. Our first question comes from Susan Nilsson.
This is Susan. My question is on the NQF 647. In regards to the 11 elements, one of them is to set up a follow-up appointment for your patient. The question I'm getting from my psychiatric department is, what about those patients who come in on a Friday, are discharged on a Saturday, and the place that they are to go for their follow-up of care is not open? How then can you document that you have set them up with an appointment if you can't get a hold of the place you want to send them to?
So, are you talking about just transmitting this record?
No, I'm not.
The next level provider is not available within 24 hours.
It's the fact that we cannot set up an actual appointment for the patient before he physically leaves our institution.
Okay. So, and I went over some of a lot of the rationale through the Federal Register, CMS, and they do touch on the fact that not all patients post-discharge are able to go to the next level provider within 24 hours. And they covered it a little bit, but they didn't really provide any kind of a concrete explanation. If you wanted to send me an email, I'd be more than happy to look into this further. And I apologize, I can't provide you with a concrete answer at this time. But it is. I'm sorry.
This is Kirk, Ross. I was just going to say, that integrated team, that was one of the functions because we were running into the same issue, having patients discharged over the weekend and not being able to call the facilities that are a Monday through Friday clinic or something to make that appointment. But again, having those bridge appointments available in-house, even for patients that we knew had established providers in the community, we could at least schedule that. That team is a 7-day-a-week team, so we were somebody in-house that we could reach to schedule a follow-up appointment with that team the next week, and that really allowed us to meet that measure.
Okay, thank you.
And Susan, this is Kim. I just wanted to ask you too, If you wanted to chat in the chat, put your email address, and Ross and I can follow up with you as well and try to get more clarification on that.
Except that I'm looking at your presentation on paper because we're having computer issues at our institution today.
Okay.
So
I'll just say it over the line then.
it's Susan, SUSAN, Nilsson, NILSSON, at northmemorial.com.
Okay, thank you. I appreciate that. And I did just want to let everyone know that we got a question from Dawn in the chat, and she was just wanting a clarification that the 3 new measures that were to start on July 1st, 2016 regarding the transition record and metabolic screening, have they been delayed until January 1st, 2017? Yes, that is correct, and I just wanted to make sure everyone saw that. Danielle, do we have any other questions queued up?
I do not see any audio questions at this time, but if you would like to ask an audio question, please press star then 1.
Okay. And I've got at least one other question for Kirk that was queued up ahead of time. So Kirk, I've actually been kind of wondering this as we've been speaking. The bridge appointments, are they essentially the exact same kind of structure that you would have in the outpatient clinic visits that would be post-discharge, or are they sort of an abbreviated visit and the goal is really to get that patient to the actual outpatient visit?
Sure. Well, a little of both. So they take on the structure of a basic clinic psychotherapist appointment. This team has the advantage with our shared electronic health record, though, that they've got that whole body of clinical information from the inpatient stay. They know what the patient's issues and goals were, and so it's really a continuation of that work that was done on the hospital side, which is what the outpatient therapist would be picking up and running with anyway. And so they start that process, and it's explained to the patient ahead of time that they're going to have this bridge appointment or appointments, and that they'll see this one provider for a couple of sessions prior to getting into the kind of routine provider.
Great. And then you did mention telehealth as well. When you do start using telehealth, is it going to be more for the typical outpatient type of visit, or are there any considerations for using bridge appointments for using telehealth for bridge appointments?
So, good question. We were thinking about using it for those typical outpatient visits, but it's an interesting consideration to use it also for bridge appointments. I think that would be helpful for, anytime there's a geographic challenge getting the provider to the location where the patient can be. Yeah,
absolutely. I know that we work with a Coalitions of Care team here at Medistar. Actually, Ross is a part of that team as well. And one of the big barriers to getting folks to their outpatient visits seems to be transportation. So telehealth could be helpful in that case. Yeah. Danielle, any questions queued up?
I'm saying no audio questions.
Okay. Well, I think that probably concludes our presentation for the day then. Just want to thank Kirk so much for taking the time to give us some great best practices. Ross, thank you for all the detail on the new quality reporting measures for IPF QR. And the audience, thank you so much for joining us today. Just a reminder, we do really appreciate getting your feedback. So you are going to be prompted with a survey when this webinar closes. And if you are going to collect continuing education credits today, then you will need to complete the evaluation survey in order to receive your certification. I also just want to welcome you to learn more about our current projects, including this one, by checking out our website, www.lsqin.org. And our emails are up on the screen, so feel free to reach out to us if you think of anything afterwards. Thank you so much.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating. You may now disconnect.